Hello, everyone, and welcome to Neurocracy. Today, we're joined by Dr. Renée Shellhaas, a professor of neurology in the Division of Pediatric Neurology at Washington University School of Medicine here in St. Louis. Her research focuses on neonatal seizures and early life epilepsy, including how sleep patterns reflect brain function in newborns. Dr. Shellhaas, thank you so much for joining me today.
Thanks for inviting me.
So, what first drew you to study early life epilepsy and neonatal neurology?
Great question. So, I am a child neurologist. I'm really interested in how children's brains grow and develop, and when things go wrong,
Yeah.
what we can do to help. And so, I trained as a pediatric epilepsy specialist, and one of the areas of pediatric epilepsy is looking at seizures and brain function in babies. And it turned out there were fewer people looking at babies than older kids and adults.
Yeah.
And I carved out a niche with a research project early in my training and became really interested in how we monitor babies' brain function. We can do that with a number of different ways,
Yeah.
but that includes EEG or brainwaves.
Yeah.
And I started my career looking at brainwaves in babies, but then I also branched out into the other different ways that we can monitor brain function in babies, including near-infrared spectroscopy, which tells us about how brains are metabolizing oxygen. And that led me to look at how babies' brain functions cycle as they sleep and wake.
Fascinating. So, could you talk a little bit about how neonatal seizures are different than seizures in later life, maybe in adults, for instance?
Absolutely. Turns out that the vast majority, like 85% of seizures that happen in newborns, are a provoked seizure. So they are a reaction to a brain injury.
Oh,
So either there was a bleed in the brain, or maybe there was a lack of oxygen, or maybe baby had a stroke. And they have what we call acute symptomatic or acute provoked seizures. Those seizures happen for a few days and then they go away,
okay.
which is different from epilepsy, which is unprovoked seizures. So
Okay. Yeah.
nothing happened to the brain. There's no injury currently, but those seizures continue to go on. And so some babies who have neonatal provoked seizures will go on later in their childhood or adulthood to have epilepsy or unprovoked seizures, but most of
Okay.
them do not.
Is there any part of the newborn brain that makes it like particularly vulnerable to seizures?
Yes.
Okay.
The way that our neurons are set up when we're babies is to be excitable. And so
Okay.
um, seizures are groups of neurons that are firing together too much.
Mhm.
And so there are a lot of different ways that the physiology of a baby brain is different from that of an adult.
Okay.
And several of those compound together to make the newborn period the highest risk for seizures.
Interesting. So, I know you talked a little bit about EEG earlier. Could you
Yeah.
expand on that and talk a little bit about how you're able to use EEG to study brain function?
Sure. So think of EEG as measuring brain waves.
Yeah.
And we put little electrodes on the scalp of any person. It could be adult or it could
Yeah.
be a
Yeah.
baby. We put little electrodes on the scalp and we're measuring differences in electric potential between the different electrodes that are on that scalp.
Yeah.
And there's a long tradition of looking at what those patterns should be. What's fascinating with pediatric neurology is what's normal when you're a newborn is not normal when you're a month old, which
Okay.
is not normal when you're 6 months, 12 months, or 12 years
Yeah.
old. So it changes over time.
Yeah. So, I know a big thing on this podcast is sleep,
Yeah.
and I believe you do a lot of stuff with sleep too. So, could you talk a little bit about sleep in newborns and kind of how maybe a little bit about like a broad picture of how it's a little different in newborns, and then how your research specifically looks at sleep and brain function in newborns?
Sure.
Yeah.
Um, so we don't expect a lot from a newborn baby, right? They need
Yeah. Yeah.
to eat and they need to sleep and they need to wake back up and eat again.
Yeah.
Right? And so they spend the majority of a 24-hour period sleeping. And that's not by accident, right? So
Yeah.
there's an important function that sleep has. Baby sleep patterns are different from older children and adults. So
Hmm.
they go first into rapid eye movements or active
Oh, okay.
sleep,
Yeah.
and then they cycle into deeper sleep and back up to awake. Um, and they cycle on about a 60 to 90 minute um, pattern.
Okay.
And so as we get older, their distribution of what kind of sleep-wake cycling and what sleep-wake stages changes
Yeah.
as we mature. And as that time that we spend asleep decreases and consolidates, right? Um, any parent has worried about their baby's sleep because when babies don't sleep, the parents don't sleep, right?
Yeah.
Uh,
Yeah.
and so babies wake up so that they can eat and they can interact with their world and they go back to sleep. Um, when a baby is sick and they're in the hospital, um, we do whatever we need to do to take care of them.
Mhm.
But in many instances, that will influence their ability to sleep. And so there's increasing recognition that protecting sleep in an infant who's at risk because they're sick for whatever reason in the hospital
Yeah.
uh, is important. And believe it or not, that's not something that we have thought about until relatively recently.
Yeah. I actually, I remember I was talking with Dr. Raman Malhotra at WashU about sleep and brain injury actually, and how people actually used to get like woken up so that like they could check, how they're doing and if they're conscious or not. But
Right.
that's actually interrupting that sleep that's so crucial to the repair of
Right.
like neurological damage.
And
So
and turns
actually,
out babies don't complain when you wake them up, right?
yeah, yeah,
They
that's
talk
true.
to you to
Yeah,
say, "Hey, stop that." So
yeah.
so we just do it, and that's probably not the right thing to do, right?
Yeah, yeah. So, in newborns with like a neurologic injury, for instance, like what like might change with their sleep, like other than maybe like, waking up more, for instance, like are there any specific like parameters that might like be something that like change, I guess. Yeah.
Sure. So the first thing is just not having sleep-wake cycling at
Okay.
all.
Yeah.
And so we do see babies who have something called hypoxic ischemic encephalopathy or encephalopathy, which means the brain's basically just not functioning right, where they're jittery and they just don't sleep. They, they
Okay.
stay they stay up. So we see babies who stay up. We see babies with more severe brain injury who just seem to stay in quiet sleep all the time. And so they get stuck in quiet sleep that's not restorative and that's not cycling. And the longer that a baby takes to gain sleep-wake cycling, the more at risk they seem to be for abnormal development.
Okay. That's interesting. So, earlier you made a joke about how like, babies tend to wake up at different times of day. So actually, that actually sparked a question. How like, is there like a particular reason why they may be waking up like, at different times of the day? Is that like normal, like evolutionarily speaking? And, what kind of like, is there any like reasoning behind that, kind of purpose maybe?
Sure. So at the fundamental basics, babies need to eat.
Yeah.
And
Okay.
they can't last for as long as you or I can between their feedings, or their blood sugar will go down.
Okay.
And they won't gain weight back. So most babies need to eat around every 3 hours. And
Yeah.
so they are going to go through a couple of sleep-wake cycles and then they gotta get up and eat. So that's the most basic way that you can
Yeah.
look at it. And over time, they'll consolidate as they get a little bigger and they have a little more reserve.
Okay. Um, Another big topic that I talk about a lot on the podcast is sleep apnea. And
Mhm.
I believe like newborns sometimes might have like disordered breathing. So I'm just curious, could you talk a little bit about maybe how that might present in newborns, like sleep disordered breathing?
Sure. So I think what you're hitting on there is sleep is not just one thing, right?
Right. Yeah.
Sleep is all, it's sleep-wake cycling, it's
Yeah.
dreaming, it's learning, it's
Yeah.
memory
Well,
consolidation,
yeah.
um, and it's breathing.
Yeah. Yeah.
Controlled by the brain, that's why a neurologist would be interested. But breathing is important, obviously.
Yeah.
And so sleep disorder turns out to be probably a very much under-recognized problem for particular groups of babies.
Okay.
So my team has studied a couple of different high-risk groups, but in particular, babies who have something called myelomeningocele. It's a severe form of spina bifida,
Okay.
where typically the lower part of the spine didn't fuse properly, and the spinal cord can be exposed. When that happens during fetal growth, the brain stem doesn't form properly, and they have a what we call a Chiari2 malformation. And so that brainstem can be dysmorphic, not formed properly, but also is kind of squished. Those babies also often have hydrocephalus or increased pressure inside their brain from increased fluid in their ventricles.
Okay.
And we know that in older children and young adults, there's a high risk for sleep disordered breathing in people with myelomeningocele. But nobody had ever looked to see when does it start.
Yeah.
And so our group said, you know what? It may start really, really early. And there are hints from various aspects in the literature that the earlier that we can diagnose and treat sleep disordered breathing, the better the outcome for the child, whether it's for their general health or whether it's their development or their behavior. And so we joined with 8 other groups, so 9 total groups across the United States
Wow.
to recruit babies with myelomeningocele. We recruited 173 babies with myelomeningocele and did a formal sleep study called a polysomnogram
Okay.
at their bedside in the hospital before they went home from the hospital. And what we found was that more than half of those babies already had sleep disordered breathing.
Wow.
And many of those babies were then discharged to home on treatment, which for a newborn is usually supplemental oxygen. So think about the nose cannula
Okay.
babies will wear. So this is a big deal. If we think, at least half of these babies have a sleep problem right from the beginning, there's an opportunity to intervene early and a potential that could have a meaningful benefit that will last for their whole life.
Yeah.
That's something that I can get behind.
Yeah, yeah, that's true. Is there anything that parents might or that you would recommend like parents look out for in newborn sleep, for instance, or like any features that might like warrant some talking with a clinician, for instance?
Sure.
Yeah.
So first of all, it's normal that babies sleep a lot, but it's also
Yeah.
normal that they wake up frequently.
Yeah. Yeah.
It's really important for families that they ask for help if they have a question, if they're worried, talk to your pediatrician.
Yeah.
That's the first thing.
Yeah.
Second is that sudden infant death syndrome or SIDS, which is death in an infant for no obvious reason. The risk of sudden infant death syndrome goes down if you sleep a baby on their back every time alone in their crib. So that means no fuzzy blankets, nothing else in the crib, no teddy bears, no pillows,
Yeah.
just baby alone, not co-sleeping with a parent, reduces the risk of SIDS. So that's really, really important for everybody to know about. As babies get older, their sleep should consolidate. That means they have a longer period of time when they're sleeping at night, and they're going to have some naps. If that doesn't happen, that's a time to be talking to your pediatrician.
Yeah.
If your baby seems to have to choke or gag, or have pauses in their breathing when they're sleeping,
Yeah.
definitely you want to be talking to your pediatrician. And if they don't get to what we call a normal circadian rhythm, where they're sleeping at night and more awake during the day, that's another reason to talk to the pediatrician. And to maybe, for all of those reasons, right, would be the next step would be a referral to a sleep medicine physician.
Yeah. So I know at the beginning of the interview we were talking about neonatal seizures.
Yeah.
But I guess I don't like I don't know too much about like what that like looks like in a baby, for instance. So
Yeah.
let's say like a parent is watching this interview and they just want to know
Mhm.
like what that might look like in a baby or a newborn.
Sure.
What does it kind of like
What
present?
does a seizure look like in a baby? So the
Yeah.
truth is that it's really hard to tell when a baby's having seizures. So
Okay.
there's no fault if a parent can't tell.
Hmm.
The other truth is that parents know their children the best. And so if your baby is doing something that's concerning you, you should ask for help. Neonatal seizures tend to happen repeatedly. So it's not usually a one-time event. Babies will have multiple seizures, and they tend to usually be the same pattern every time. The most accurate semiology, or it's the word that we use for sort of pattern of a
Yeah.
seizure for a newborn, is something we call focal tonic or focal clonic seizure. So that means one part of the body, so say it's the arm, may stiffen, that's tonic.
Yeah.
or shake. That's clonic. So that's rhythmic shaking. You
Okay.
see that in a baby, that can be an emergency. That's an immediate call for help. Typically, that will happen in the context of there's something else going on with this baby. They are not they're not doing what a normal behavior baby should do.
Yeah.
They're not waking up. They're too sleepy. There's other things going on.
Okay.
Doesn't usually happen aside from that.
Yeah.
Can,
Right.
but not usually. Again, those acute seizures tend to go away. Babies with epilepsy, it can happen that a baby has epilepsy. They tend to continue to have those same seizures over time. Because neonatal seizures are associated with infections and injury, it's an emergency. So that warrants going to the emergency department for an evaluation, or if they're already in the hospital, they go to the intensive care unit.
Okay.
Over time, most of those babies will not have any more seizures. I have another group that I work with called the Neonatal Seizure Registry. It's a separate 9-center across the United States collaborative that I run with Dr. Hannah Glass at UCSF.
Okay.
And we have followed hundreds of babies from the time they were diagnosed with neonatal seizures up through childhood now. And like I said, most of them don't have epilepsy, but about 20%, 1 in 5, may have epilepsy later in their childhood. Many of them are doing very well going to a typical school, kindergarten.
Yeah.
But there are some who need more help and may have more subtle things like ADHD, sensory processing disorders, or may have more significant disability. Turns out we actually asked a group of parents whose children had neonatal seizures and were now 5 years old about their children's sleep, because we had heard anecdotally that sleep was a problem for these kids.
Yeah.
And we found that more than 2/3 of them actually do have clear signs of sleep disorders at
Okay.
school age. Worse if they had epilepsy, cerebral palsy, or intellectual disability. But even kids who otherwise were doing well, very, very often had behavioral sleep problems.
Yeah.
And about a quarter of them screened positive for sleep disordered breathing on validated surveys.
Yeah.
Also of interest, the kids who had sleep problems at school age, their parents had increased symptoms of anxiety and depression. So we know kids' sleep affects the whole family.
Right.
Something that I would reiterate again, if your child isn't sleeping properly, you got to talk to your pediatrician
Yeah.
so that we can get it taken care of.
Yeah. Yeah, I was actually the question kind of popped in my head, like, are there any features in sleep that might like be predictive of developing epilepsy in later life after neonatal seizures? So is that like I think you kind of like answered that a little
Yeah, it's
bit.
a good
Yeah.
question. We know that babies who have really severe abnormalities on their EEG, the brain waves, when they're
Okay.
newborns, and they've had seizures, they're at higher risk for developing epilepsy later in
Okay.
life.
Yeah.
And part of being a very severe EEG would be abnormal sleep-wake cycling.
Yeah. Okay. So I guess the other thing I wanted to ask is like what kind of like interventions or screening tools are there any that kind of exist right now that might be like helpful in terms of identifying these abnormal like patterns or brain activities? And I think like the EEG is definitely like one as we like are talking about it, but are there any like other tools maybe that exist?
Yeah, so for toddlers and school age children, we do have validated questionnaires to get
Okay.
started.
Yeah.
So there's something called the Children's Sleep Habits Questionnaire, which is very commonly used, that looks at behavior around sleep.
Hmm.
There is something called the Pediatric Sleep Questionnaire, sleep-related breathing disorders subscale, which has really good correlation with sleep disorder breathing diagnoses.
Yeah.
So for 2 years old and up, we have pretty good sense of ways that we can start screening just with a
Yeah.
questionnaire, which is helpful. For younger children, it's a lot harder to
Yeah,
get
that makes sense.
at a screener. And so we think about high risk groups. So our babies with myelomeningocele are clear, right?
Right.
We also have babies who are born with very small jaws or small mid face. They're going to be at higher risk. Or babies who are born with abnormal tone, whether it's too high or too low,
Hmm.
that changes their ability to protect their airway when they're sleeping. So there are a number of other high-risk categories that warrant careful attention. And the gold standard is going to be something called a polysonogram. So that's a combination
Yeah.
of EEG, looking at brain waves, looking at eye movements, looking at respiratory, breathing in and out through your nose, in and out through your mouth, looking at your heart rate, respiratory pattern, pulse oximetry, so oxygen in your blood. That's done at a specialized center and evaluated carefully by a specialist, but that is the gold standard for looking at most
Yeah.
sleep issues in
Yeah.
young children.
So my last question for you is kind of
Mhm.
looking more futuristically. I just want to ask, like, what kind of questions in your research are you looking forward to answer, or most excited to approach?
Sure. So first is let's figure out who are those high-risk babies.
Okay.
And if we can figure out who they are, then what interventions and at what time point in their infancy, will give them the best benefit. So we know for school-age children who are otherwise typically developing but have sleep disorder breathing, have obstructive sleep apnea, doing tonsils and taking out tonsils and adenoids improves their behavior and quality of
I
life.
actually got my tonsils removed, so
Oh, there you go.
yeah, yeah,
And we know that for some high-risk groups, like babies who have trisomy 21 or Down syndrome, that earlier diagnosis and treatment of obstructive sleep apnea improves their development. So
yeah.
what about other high-risk groups? And can we diagnose early,
Hmm.
intervene early, and improve their quality of life and their development?
Yeah,
Those are the kinds of questions that I think really are field leading at this point, and are really exciting because if we
yeah,
can make an intervention that helps a baby's development from the very beginning, that is going to improve their whole life,
yeah,
and that of their families as well.
yeah. On that note, Dr. Shellhaas, thank you so much for joining me today. This is an eye-opening interview. I never really thought about how sleep presented in newborns and the kind of like brain activities associated with and how like seizures and sleep are actually very interrelated. So, um, yeah,
They
thank you for joining
absolutely
me.
are. Thanks for your questions.
Oh
And
yeah,
yeah, I'm on a mission to make sure everybody's thinking about sleep in babies. So thanks for helping me.
yeah, yeah. Thank you.
You bet.